World Reimagined events, we've been looking at the National Care Service and what that means. And this theme has come up so much about how we include people. And I'm just so looking forward to hearing from our colleagues across the globe on what they can share with us and our learning to take this forward. We're using Zoom, there is at the bottom the chat, so please feel free to use the chat to say hello or to put any thoughts or share as we go. And I do want to acknowledge, excuse me, that it's Carers' Rights Day today, so a very warm welcome if you are a carer or you support a carer or you have a carer, and a huge thank you for all that you do, because without you, we'd be in more of a pickle than we are. So thank you so much, and I'm sure you'll be aware there's other events happening today in terms of support for carers, and I hope that this event and others will help us to improve what we do for carers and with carers and all in the sector. So I'm going to pass over. We have Elke Loeffler, who's Associate Dean at Strathclyde Business School, and a huge thank you to Elke for bringing all her colleagues and team together. It's a real team effort today. So I'm going to pass over, and just thanks again to everyone for their contributions today.
Okay, many thanks for the kind introduction, Sheena. And on behalf of our international team, a warm welcome to all participants. We are absolutely delighted that so many of you have joined this event. And in particular, I would like to thank the GCVS for hosting this event in partnership with Strathclyde University in Glasgow, and also thank the Scottish Co-Production Network for supporting the marketing of this event during Scottish Co-Production Week. Well, it seems, given your interest, your participation in this event, that this theme is very timely. Co-production in Scotland, international lessons on tackling inequalities. And we have to admit that we've got more questions than answers. And we would very much like to discuss with you today how we can reduce health, but also social inequalities through user and community co-production. For us, this event is also the beginning of the planning of a joint research project. So if you are interested in this issue and you would like to work with us, please get in touch with us. And of course, if you have a big pot of money, please do let us know. We would really like to have a chat with you. And obviously this would help us a lot with our research project. So what do we have for you? Well, we've got 4 co-production case studies from 4 different countries. And this includes, first of all, a case study on drug rehabilitation, co-production of drug rehabilitation in Italy, which will be provided by Denita Sebico. Denita, if you could give a wave to everybody. So Denita, thanks Denita. So Denita has joined us from sunny Rome, I guess, probably not as cold as in Glasgow. I'm also delighted to have my colleague, Professor Beth Weaver with us, who will talk about another fascinating case study, which is about co-designing more inclusive social services in Scotland. Obviously, as Sheena said, a very timely topic. Beth, if you would say.
Hi everyone.
Thank you, Beth. And I'm also delighted that we've got 2 colleagues from the University of São Paulo in Brazil with us, Patricia Mendonça. I hope I pronounced your last name correctly. Patricia, still have to practice. And Andrea Aquino, if you could say hello to everybody.
Yes, Elke, perfectly. Patricia Mendonça.
Okay.
Hello,
Hi.
glad to be here. Hi.
Hi, thanks, Andre. And Patricia and Andre will be introducing to you an interesting project about peer testing for HIV, co-production, overcoming stigma and discrimination in São Paulo. And finally, we've got a case study from the US for you, which is about co-producing community healthcare in Portland, Maine, But as you may reckon, today it's Thanksgiving in the US. So our colleagues will be celebrating Thanksgiving, cannot be with us, unfortunately, but they have produced a short video, which we are going to show you at the end of the presentations. However, we should have a colleague from Canada with us, Riley Livingston. Riley, are you here?
I'm here.
Wonderful. So, and Riley will be helping us with the facilitation of a breakout room and of course bring in also perspectives from Canada. So I think this is a truly international co-production event today. Martha, could you move to the next slide, please? So this brings me to an icebreaker, which this time will be an individual icebreaker. And we would like to invite each of you to think about things citizens are already doing that public services could benefit from, you know, if they would use it more systematically to improve public services or outcomes. So have a think and please feed your answers into the chat line. Our colleagues from GCVS will be gathering everything you feed through the chat line, so nothing will be lost. And this also applies to the case study presentations. Unfortunately, we don't have time for Q&A right after each case study, but if you have any questions, please feed them through the chat line and the case study presenters will pick this up and get back to you. And if we overlook something, our colleagues from GCVS, they will certainly get in touch with you after the event. Okay, so I hope there's already some interesting propositions coming through the chat line. This is also an issue you may want to discuss tonight with your family at dinner table. I'm sure you'll find a lot of things, you know, communities are doing. It's often invisible, but actually there's already a lot happening out there. So please continue the conversation. And I suggest we move to the next slide. Okay, which offers you a definition of co-production. Obviously, that's the topic today. And the definition which I have used in my research says that co-production of public services means public service organizations and citizens making better use of each other's assets, resources, and contributions to achieve better outcomes or improved efficiency. So it's not just about fish and chips, but it's certainly about synergy. I don't know in Brazil which icon would be appropriate, so you may have to adapt the graphic to your own country and community. And of course, most importantly, I think it's important that you develop your own definition of co-production and that you co-produce it with your stakeholders rather than copying something from the internet. But of course, as we all academics will be flattered if you use our definition, but please adapt it to your context. Okay, I suggest we move on. Oh, yeah, Patricia says rice and beans would be the Brazilian icon. Okay, we'll internationalize that for the next event. So what does co-production mean in practice? Well, it means both citizen voice and citizen action. It could, and here are 4 key co-production approaches. The first one, co-commissioning. You could also use the term co-planning. This is about deciding together what's important. Co-design. This is typically about innovating together, finding new solutions. Co-delivery is about joint action, and co-assessment is about exploring together which pathways to outcomes are most effective. So very importantly, co-delivery, it's part of co-production, as I said, not just citizen voice, but citizen action. I think all the case studies which we will present will reflect this range of co-production. Okay, we can move to the next slide. So this provides you with a conceptual model for framing all the case studies which we are going to present. It shows you different pathways to reduce social and health inequalities. And as you can see from the graphic, we suggest there are three main pathways to reduce social harms from problems. The first one is about prevention, to prevent occurrence of problems. The second one is about improving treatment. And the third one is about improving rehabilitation after treatment. Now, Denita's case studies about co-production of drug rehabilitation with drug users obviously focuses on the rehabilitation pathway. I think, Beth, your case study includes all three pathways, and the Brazilian case study will mainly focus on prevention, whereas the US case study, again, I think it includes the whole range of co-production pathways. And of course, our research is going to focus on how co-production can be designed most effectively so that it achieves maximum impact in order to reduce social harm from problems. Okay, so far about the conceptual framework, and I suggest we now start with the Italian case study, and I would like to invite my colleague Denita Sepicu from the University of Tor Vergata to talk about her case study, the San Patrignano community and co-production of drug rehabilitation in Italy. So Denita, you've got the floor.
Thank you, Elke, and thank you everybody for at the Glasgow for having invited me in this important initiative. Well, I've been invited to talk about the San Patrignano community. The San Patrignano is now one of the largest drug rehabilitation communities in the world, but it started in 1978 with one single teenager who sought help in a family, and this family understood the importance of providing an answer to drug problems that were rising in the country and to which the state was unprepared at the moment. So 7 families gathered. So it started as a philanthropic initiative. 7 families gathered. They put their properties, a hill in near Rimini in Italy, a hill and some buildings to host teenagers that joined the community. Today, if we can move to the next slide. Thank you. Today, the community hosts 1,500 people. At some points in history, they have hosted 3,000 people altogether. 24,000 people have been helped since its foundation. So it started as a very family philanthropic initiative, and now it is a foundation. It is a social enterprise that manages 35 million euros. It has 3 branches. It has 57 activity areas. These 57 activity areas are very important because on one side, this provides profit that covers 50–60% of the operating costs of the community. On the other side, these areas are the areas in which the rehabilitation program works. So the drug addicts are provided with education, professional training, and a job inside these activities. The last important thing to say is that the community relies on a little bit more than 100 volunteers and 300 collaborators, professional collaborators. Next slide, please. You see these are the early pictures in 78. In this slide, you can see some pictures of the people that work, live, train inside the community, and the 57 sectors are from wine to restaurants to leather and fashion to graphic design. Wine of San Patrignano is very famous worldwide. So a lot of Italian excellence sectors, and indeed the principle they follow is excellence. So if you go and have a look at the shop of San Patrignano, you see the product. Next slide. Also, there are some pictures just to give you an idea. Below is the restaurant. There are some furnitures, leather products, artisanal products, etc. Next slide. Okay, so this is the community. What you see above are the homes, because it is a living community. People cannot leave the community. They cannot get out of the community in the first year. Afterwards, it is possible. And the rehabilitation process lasts 3 years. So these are the houses where they live. It's like a mini city, because if you think 2,000 people living in a rural area, it's like a mini city, which is self-sufficient. Below, this is the canteen when they have breakfast, lunch, and dinner. And it's really impressive. It is called the ship, because you see the roof. It looks like an upside down ship, and it's very impressive to eat there with all these people and to see the energy that is inside. So there are two specific characteristics of this rehabilitation community. The first one is that the rehabilitation method is based on making these people again believe in themselves, giving them a sense of worth, providing them with a job, making them believe that they can do something, they can have a valuable life. And the community, thus, is a very important part. The rehabilitation does not include any pharmaceutical cures. Of course, there are people with HIV or other, and these are, of course, treated. But all the other people, the drug addiction is not treated, is not addressed with other drugs, with pharmaceuticals. It is simply providing a job, providing rules, work, providing a routine which they do not have. And each person is part of a group and has a tutor who is part of the people that live in the community. So this is the first characteristic. Next slide. The second, which is maybe more important for our conference today, is the co-production approach. Now, we can look at the community of San Patrignano, of course, as a partner of public administrations. And indeed, since 1983, they work with criminal justice, with prisons, to help prisoners that are drug addicted. They work with the hospitals, they work with the schools on prevention activities. But there is another co-production element, which is not so visible from the outside, but is fundamental for the success of the rehabilitation method. And it is this one. 90% of the volunteers and of the professional collaborators, so the doctors, the trainees, have been drug addicted in their past. They have a past of drug addiction. And 32% of them, so 1/3 of them, come from the same rehabilitation process in San Patrignano. This characteristic, this feature is very important. First of all, to establish a strong trust-based relationship with the people there, among the people there, because drug addict people that are undergoing the rehabilitation process have in front of them professionals that represent the success of the rehabilitation method. They represent the high probability that you can make it, you can do it. I did it, you can do it. So this is a very important element, also because the professionals and the volunteers know very well what the temptations can be, what the difficulties can be to move to a normal life and independence from drugs. Next slide. So the rehabilitation model of San Patrignano and the community of San Patrignano has been evaluated in several studies, but one of the most recent one by University of Pavia has shown that the success rate is of 72%. So 72% of people that enter the community do not go back to drugs. And there is a high percentage of 90% of people that find a job in the same sector on which they have received the training and the professional training from San Patrignano community. The average rehabilitation rate in the world is 18%, and in Italy, in non-profit programs, is 30 to 45%. So you see that there is an exceptional success rate, and this success rate is attributed to both the community approach, so not one-to-one rehabilitation process in which I prescribe you some drugs and some activities, but it's a community. There's social control and the relational capital, and also on the co-production process, on the big trust that empowers the relationships between drug addicts and people that want to help them inside the San Patrignano community. And this program has achieved several awards. Also, it's been recognized by the United Nations also as one of the most effective approach to drug addiction. Next slide, which maybe is the last one. Yes, these are some references, the website of San Patrignano, and also a paper which basically describes the history and how succession has been managed from a family firm or a family cooperative to a big philanthropic project to a social enterprise. And that's it. Yes, thank you for your attention. Your microphone, Elke.
Oh, sorry. Yeah, many thanks, Denita, and a round of applause. There's some icons at the bottom of the Zoom. So many thanks. I think that was very clear, and I think, you know, your photos already speak for themselves. And Denita, you said it's possible to visit San Patrignano, so that may be an idea for your next holiday in Italy.
I can help organize if any of you is interested in visiting. Of course, the community is a closed community, especially now during COVID. Visits are not allowed.
Is it possible to? Denita, is it possible to order the products online, because these could also be nice Christmas gifts?
Yes, it is. It is possible, and I have already ordered something for Christmas. Yes.
That's great. So any questions to Denita, please use the chat line, and Denita, if you could get back to everybody who raised a question regarding your case study. So many thanks for that.
Thank you.
And I think we'll now do a very quick journey from Italy back to Glasgow. So I would like to invite my colleague Beth Weaver to introduce her case study. So Beth, you've got the floor.
Thank you very much, Elke. So today I'm going to talk about co-designing more inclusive social services, drawing on an Ayrshire case study, specifically in justice social work services. Martha, do you mind please changing the slide? Thank you. We know that co-production needs to become essential to the way Scotland works if we are to achieve the services which Christie envisioned and achieve better outcomes for people and communities. Co-production is consistent with efforts to challenge the exclusionary nature of much ideology underpinning existing or top-down health and social care policy and practice, and to help us move towards more inclusive and participatory approaches. However, there are certain groups, sometimes referred to as hard to reach or seldom heard, whose voices are often absent or overlooked, and who face quite significant social and structural barriers that challenge their meaningful participation in co-production activities. People involved in the criminal justice system are among those groups whose multiple marginalities and stigmatized identities and relationship to services, which is typically involuntary, has resulted in justice contexts as an unlikely space for co-production. Indeed, unlike many other service user groups, their participation in the service itself can be a source of stigma. So we were commissioned to undertake action research with 3 local authority providers of justice social work services across Ayrshire and with service users to inform and support the design, development, implementation and review of a co-productive approach to doing justice. Because such examples of working co-productively with this group and in this particular context remain relatively scarce, we literally approached and developed this from the ground up. So we worked with service users and social workers and team managers and staff from various third sector organisations. And we did this using techniques of community mobilisation. Now, community mobilisation is a process for reaching out to different sectors of a community and creating working partnerships to focus on and address a key issue. So it's about empowering different individuals and groups to take action to facilitate change. In this presentation, rather than focusing on criminal justice as a context, I want to focus on the implications from our learning on this project about how other organisations and groups might co-produce or co-design more inclusive social services, whether they be statutory or third sector, and how we might go about supportively engaging service users in the design, development and delivery of services. So we worked with social workers, third sector agencies and service users to bring them together to support them to work to co-produce innovations in the design and delivery of justice services. I don't have space to go into all the detail, but as this afternoon progresses, I will put in our good practice guide in the chat for other people to go into if they so wish. But what I want to do is talk about how we went about it, what and how our service users wanted to co-produce, and the differences it made. Martha, can we change slides, please? How did we encourage people to get involved? Well, people are unlikely to get involved if they don't know what they are signing up to. Methods of recruitment should maximise all opportunities to explain the aims and purposes of your group or project, tell them what's expected of them, and tell them what they can expect from you. I mean, you might find it helpful to develop a recruitment plan. We did, and we used a range of different methods which we developed in partnership with service users. And these included designing and distributing a promotional flyer or poster, and we put these up in interview rooms. We distributed them to different agencies in groups. We put up TV screens, advertising events and activities in the same way that you might find in the UK in GP waiting areas in the old days. We hosted awareness raising events, participatory workshops, outreach activities, and we also found that offering short training courses to service users who are keen to co-produce was a really effective route into involvement because it enabled people to form a naturally forming group through that mechanism, whilst also giving something back. And that included skills and training that people could use in other contexts. Word of mouth, encouragement by practitioners or peer workers with whom service users have a good relationship is incredibly effective too, actually, particularly if they provide practical support to engage. Leadership from people with lived experience is key in terms of reducing social distance through what we call identification-based trust. And this encourages participation and engagement. Can I get the next slide, please, Martha? There's some practicalities to take into account and differing approaches that can encourage participation. And I think key is to make it as easy as possible to get people involved. Think about the accessibility of the location of events or activities. Make sure people feel valued, supported, and welcome when they do get involved. I mean, meetings or activities should be informal, warm, friendly in approach, while ensuring they are focused on the purposes at hand. And ensure you take time to prepare and support people for different opportunities, providing or negotiating access to training, for example, where it's applicable to do so. We found that regular meetings or activities enable and encourage participation, while also communicating reliability, and enabling a sense of progression. When we had meetings with service users, we gave out an agenda in advance. And I know that sounds quite formal, but we found that if that was shaped by the discussions and actions for the last meeting, it really held people accountable, and it conveyed that people's views are both heard and acted on, and the importance of feedback cannot be overstated. Now, while serving their own purpose, meetings are not necessarily an attractive mechanism of engagement for everyone. Some people, particularly the groups we worked with, prefer specific activities with a specific purpose. If you're engaging a diverse group of service users with different capabilities, motivations, interests, and experiences, well, that really requires the development of different opportunities to get involved, from one-off encounters or events to ongoing activities. The environment in which these meetings, activities, or events takes place should be welcoming and neutral. So rather than meeting in statutory justice services, we met in a local community centre, but different services and different service user groups might prefer something different. Travel costs were reimbursed to make sure people weren't out of pocket, and we arrange transport where public transport is unreliable or infrequent. We always provide food, and I think that conveys something of a sense of value, worth, and appreciation of people's time. We only use first names, we leave roles and titles at the door, and I think that also conveys a sense of equality, inclusion, and mutual respect. I think it's also important to stay in touch with service users in between meetings, events, and activities through whatever means they are most comfortable with. It's so important to take an interest in people, in what matters to them, because relationships are a two-way street and they really need to be nurtured and maintained. We need to put service users' needs first rather than our own agendas. Service-led approaches that don't reflect the values and interests of service users are unlikely to encourage engagement. Service users involved in our project undertook surveys, and they sat talking to other service users while they were waiting for their appointments about what they might be interested in, about what matters to them, how, when, and in what capacity they might like to get involved. Great advice would be persistent. If something doesn't work, try it again. It might work next time, or do it differently. But remember, it takes time. So just make sure the experience is fun and enjoyable. And it's okay to make mistakes. You might, we did. Just own them and work together to see how you do it differently next time. Key is to make sure that you listen carefully to what people want and make sure that they feel comfortable to have their say. Relationships and mutual trust are key to co-production, and this can be enabled or constrained by how we interact with people, our attitudes, and the nature of the relationships between practitioners and service users. Cultural and relational dynamics shape experiences of participation. Risk-averse cultures and reluctant staff can negatively affect service user experiences and affect the enthusiasm of other staff. Forums, meetings, focus groups, and consultations are less engaging for some people than actual activities and events, and we found this was particularly the case in justice contexts. So the focus, nature, and variety of opportunities for co-production, reflecting different stages, capabilities, motivations, and interests is key. The meaning or value of what people are being asked to participate in matters, being heard, feeling listened to, having an impact, being informed of the outcomes and effects of engagement, and seeing evidence of change is so important. This might include tangible benefits at the level of the individual or at the level of the service. Martha, can we take the next slide, please? So what did we achieve together? Well, we established, as you can see from this slide, a walking group, weekly gym offering boxing training and circuit training, football training, fitness initiatives, a book exchange, a film club, a social media account, a newsletter, a cooking group. All the different groups initiated changes to feedback pro formas at the institutional level. So that included review minutes, exit questionnaires, devising an entrance questionnaire, a suggestion box. We co-produced mentoring projects, mutual aid groups, training projects, and recovery support groups. We made changes to the physical environment of services, and that included waiting rooms and interview rooms. We involved service users in government and service or strategic consultations. Our activities enhanced partnership working between agencies, leading to the co-production of resources and activities between us. And we created new paid posts for people with lived experience to directly shape justice services. Next slide, please, Martha. So what difference have they made? Well, for service users, they reported shifts in their personal and social identity, shifts in self-worth, self-esteem, enhanced self-confidence and a sense of self-respect, mutual support and a sense of community, a sense of making a difference, finding a sense of belonging, enhanced engagement. And it really, in sum, encouraged and supported processes of change and created opportunities for social participation. Practitioners said they felt part of a positive movement for change. They experienced a shift in how they saw service users, and they found they had an enhanced understanding of service users' experiences of services. Participation in the groups gave them an opportunity to work with, communicate and relate to other people who use services differently and in different settings and for different reasons, which gave them a renewed sense of purpose. In terms of organisations, managers said it improved their services, that interventions or practices were more meaningful and effective. It improved communication and engagement, and it dismantled barriers between professionals and service users. If I can go to the last slide, please, Martha. I'm hoping that this very brief window and whistle-stop tour has helped inform how we went about co-producing more socially justice services. I'm really looking forward to hearing how this might connect with your experiences or inform new approaches in your setting as the afternoon goes on. Thank you very much.
Okay, many thanks, Beth. I think that was a fascinating case study of co-production in a criminal justice context, and obviously far from being mainstream, so there's still lots of challenges. But as Catherine said, you know, the challenge we often experience is that co-production is just tokenistic, and I think that certainly wasn't the case in your action research. And again, Beth, as you said, if you could just provide the URL with the toolkit in the chat line so people can read more about the work you have done. And of course, if people have any questions, please feed it back to Beth either via the chat line or directly by email. Okay, so we are now moving on. We are now taking a long distance flight to travel to Brazil, Sao Paulo, where Patricia and Andre got involved in an interesting co-production project in working with people with HIV experience, and obviously this is a community often experiencing stigma and discrimination, so it's again a very challenging context for co-production. So Patricia, we're looking forward to hearing more about your work. The floor goes to you.
Right. Thank you, Elke. Thank you for our hosts in Glasgow for this invitation. I apologize that my colleague Andre, he had to leave. He was just able to say hi, and I will conduct the presentation. We can move for the first slide, please, Marta. Okay, I'm just giving a background. This case is about the city of São Paulo. São Paulo is the largest metropolis in Latin America. It has currently around 12 million inhabitants. It's also a financial and cultural center in the country. It's very a favorable scenario for to happen what the people say risk scenarios for HIV and all other sexually transmitted disease to happen. Since the beginning, we are talking about back in the 80s, okay, there are some vulnerable groups to the HIV epidemics. In Brazil, there are sex workers, injecting drug users, prison population, and more recently, young people and trans women, okay. São Paulo was a pioneer in the country in establishing strategies and actions to deal with this problem that was arriving in Brazil and in the world in the mid and late 80s. And it acted very fast to deal with the problem. While many other health services at that time was closing their eyes for the problem because it's very difficult to work with sexually transmitted disease. And especially in the case of AIDS, that was since then and until now, a disease full of involved in prejudice and discrimination of this vulnerable population. So the city was the first to establish services and activities and efforts to deal with that. And it also inspired the creation of the Brazilian national program to fight HIV. In fact, this program was world recognized as because it was very early established, and also because it reached a lot of sources in terms of prevention and treatment. And since that time, there was a large tradition of working with social movements and NGOs. Both existent NGOs that worked in several issues, and also NGOs that emerged at that time to work specifically with HIV problems. And also they have, since that, connections with many different social groups, such as gay movement and also the Catholic Church. They worked together since that time until very few years ago. Can we move for the next slide, please? So continue with this tradition, until now, this tradition of participation. The municipal health department has a specific coordination unit for sexually transmitted disease and AIDS, okay? This unit, it manages 26 specialized facilities that deal only with STD and AIDS. It has also an educational division that work with the rest of the health network of the city of São Paulo, which is very big. Basically in training for other health professionals to deal in non-specialized facilities, such a big general hospital, for example, to deal with specifically with this issue. And it also have a division for prevention and articulation with civil society. So they think about those things together. Can we move to the next slide, please? Okay, so what are the prevention actions that are taking place right now in the city of São Paulo? Okay, they do those education and training programs with other health units and also within their specialized facilities. There are great variations in a way that all non-specialized health services deal with STD and AIDS. Concerning specifically the specialized facilities, they have preventions that they call extramural. When they go out of these 26 physical facilities to the streets, to public space, square parks, metro stations, bus stations, and they have two mobile units that they call two vans that are adapted to give out some prevention actions. They also do that with partners. They go to cultural centers, they go to community centers.
Patricia, you muted yourself.
sorry. Okay, they have the extramural with their own mobile units, and also they finance and support activities with partners. Our partners also have mobile units and other strategies to work with preventions. And they have what they call voluntary prevention agents, which are people from these vulnerable groups that are recruited. They are voluntary, and they receive allowance for transportation, and they work together with the staff from these 286 specialized services. Can we go for the next slide, please? These are the activities that are performed in these different prevention actions. Not all of them, they perform all of this. They might do one or two things only, but these are all the portfolio of services they offer. One of the most important is testing. Testing is a very important strategy today, and not in terms only of the policy in Brazil, but worldwide. UNAIDS has these goals of testing most people as they can, so because they can go on with treatment and other strategies, testing is very important. So I will present some pictures, some photos of these prevention activities. We can go on the next slide, please. This is the van, the mobile unit. It's from the municipal services. The other one, please. Next slide. Okay, this they are it's evening. It's outside. The normal service hours, including weekends and holidays. They can go. It's very important that it's happen outside the normal hours. Next slide, please. This is another, it's from an NGO partner. They also have their mobile units. Next slide, please. And NGO partners also have other actions and communications, and they distributed. These are young people in the periphery of São Paulo. There are also barriers to access health services because of social economic inequalities. Next slide, please. And these are pictures from the prevention, what they call the prevention agents, which are these voluntary recruited from vulnerable groups. These are out in the social networks of the municipal health. And the next slide, please. It's very important that they can communicate using their own language. For example, she is talking and using in Portuguese. It makes a lot of difference. It's not so much maybe for English with he and she, her and his. We call the gender neutral language. So she uses this kind of gender neutral language. Next slide, please. And so what this allowed to do, this kind of partnerships and approximations with vulnerable groups, volunteers. This is the pandemic, sorry. During the pandemic, I thought people would stay at home, but it was not true. The risk scenarios continue to occur. And what happened? Many actions, they could not be done, of course, because they were dependent on having a lot of people together. But the prevention agents, they continue to work a lot. And they were very creative in mobilize virtual means. And it was very important. And also the STD/AIDS coordination unit increased its presence in social media. The next and the last one, please. What are the benefits of co-producing with these partners? First, it breaks social economic barriers to access to health services. breaking stigma barriers to access specialized HIV services is not easy for, and there are research that show that there is a UNAIDS called stigma research that measure how much stigma is a barrier for people living with HIV to access any kind of health services. So in this outside, extramural strategies, they can work in space that are created or made available to people, to avoid this bureaucracy of, from 9 to 5, during weekdays. And also it's working with people from these vulnerable groups. It's very important to enhance the dialogue. It's very important to use their own language to talk about sexual behavior and break lots of barriers and misinformation that people have about sexual behavior. And it's very important to point that after testing people, they are only not just do the test, it's also doing together with counseling services, including offering PrEP, which is a kind of prevention treatment based on antiviral medicines. So it's very complex, this case, a lot of things to talk about. I hope I was enough clear for you. Thank you very much.
Well, many thanks, Patricia. I think that was really inspiring. And again, any questions to Patricia, please feed it through the chat line. I've noticed on a number of posters, it said IST, is that HIV in Portuguese?
No, it's HIV. IST, it's they call an infectious sexually transmitted disease.
Okay.
Yeah,
that was just a question from the chat line.
Sometimes it appears they call IST or STI. Sorry about this confusion because they changed it.
Okay. Thank you. Thanks for this clarification. So again, the chat line or emails are open to Patricia. And as you will see at the end of the slides, you have the contact details of all the speakers. So don't hesitate to contact us if you want to have further information. And I think now Martha is getting ready to show us a video of our American colleagues, Tina Foster and Rachel Forcino. Wonderful. So that will take about 10 minutes. And afterwards, we are going to have a break of 5 minutes before we start the breakout room. So 10 more minutes, and then you can have a brief break. So many thanks for your attention.
Hello, and welcome to our session on co-produced community healthcare initiatives in Portland, Maine. I'm Tina Foster, professor of obstetrics and gynecology and community and family medicine at the Dartmouth Institute, located in New Hampshire. We're very, very sorry that we are unable to be there with you live, but on the date of this actual session, both Rachel and I will be on the West Coast where it's 3:30 in the morning. And it's additionally it's one of our biggest holidays in the United States. So we're sad not to be there with you. We hope that we'll be able to view a recording of the discussion that you might have about this. And we're hoping that you might help us think about the answers to a couple of questions we'll pose at the end. Rachel.
Hi, I'm Rachel Forcino. I'm a health services researcher focused on co-production at the Dartmouth Institute in New Hampshire.
And I'm Renee Wolf. I am a physician who lives in Portland, Maine, which is about as north and east as you can get in the United States. I assume that most people know that the healthcare system in the United States has evolved into a rather convoluted and complex system. And in response to some of the unfortunate aspects of that cumbersome system, there's been a growing interest in trying to impact upstream root causes of health and health behavior. Here in the US, we spend about 80% of our healthcare investment dollars in initiatives that are based in hospitals or clinics. But about 80% of the factors that impact healthcare occur outside medical infrastructure, where people eat, work, live, and play. In an effort to shift the paradigm to focusing on community-based healthcare, the Division of Preventive Medicine that I work with has been working on several community-based healthcare initiatives. In particular, I work with immigrant communities in Maine, which is a particularly disenfranchised subpopulation. Some of the initiatives that we've been working on, which are co-produced, include the Ask the Doc series and a Project Echo series. Ask the Doc is a community outreach town hall question and answer forum where community members raise a topic that they have interest in questions about, and they bring that to their community health worker, and then the community health worker hosts a session where community members ask a doctor any question they want on that topic. We currently offer these in 3 languages, in French, Somali, and Arabic, which are 3 of the larger immigrant populations that we have. We've learned a lot from the Ask the Doc series. They've been co-produced. We've learned a lot about trust, about power dynamics, about the information that exists in the community that's not getting back to providers, and about the benefit of developing relationships so that you can impact health. The Division of Preventive Medicine got a grant to put on a series of 6 Project Echoes based on immigrant health, or focused on immigrant health. And we decided that we would use this opportunity, putting on these Project Echoes, to really push this paradigm shift that we were hoping to see, to focusing on community-based initiatives that were co-produced. The intent of our Project Echo was really to create a platform for dialogue. A lot of people are familiar with Project Echoes. They are a format or a platform for sharing knowledge between providers in central locations and rural locations. That was how they began. And we decided to use this platform to create a dialogue between upstream and downstream providers, between community members and people who are involved in providing care to those communities. We wanted to share the lived experience of immigrants in our community and educate providers about what it was like to engage with the healthcare system. And in particular, we really wanted to highlight the role of community health workers who do the day-to-day work of addressing social determinants of health, whether that's providing transportation, access to information, translating, explaining the system, giving rides, finding milk, you name it. They really are addressing the basic needs of people in our community. And so we created this series of 6 Echo webinars. The topics were decided upon by the community members as the barriers that they most frequently face. Each Echo has a 15-minute didactic session presented by a community leader who is an expert in that topic, and then a case presentation by a community health worker, which highlights that barrier. We've now completed 3 of these 6 webinars, and they have been very well attended. We have had the largest attendance of any Echo in the Maine health history. The average attendance at a Project Echo is between 20 and 30 people, and we've had over 100 at each one of our sessions. In a culture that does not always promote dialogue in general, co-production can be very difficult when you are trying to co-produce something across racial and socioeconomic divides. And certainly we have faced some challenges. We have come across some fairly significant implicit bias. We have seen some of the systemic racism that we know to be present. It has been an interesting study in power dynamics. It's difficult to have brown people teach white people about their system and what they think works and what maybe does not work. And there's a significant amount of mistrust on both sides that we're starting to broker. But despite that, the success has really been that we have created this dialogue, and we've clearly, I think, with the attendance, tapped into a real strong desire for this dialogue. We were able to co-produce it. We had not only our stakeholders, but our hub team was very balanced and was involved in the design, implementation, and revision of this series. We've done surveys and have had good positive feedback. The participants have come from a very varied background. So we've got a wide catchment. And from our surveys, we have been able to discern that we have increased the awareness not only of these barriers and the importance of hearing the lived experience, but of the role of community health workers. Tina, I wonder if you could just talk a little bit about your experience with co-production and community outreach.
So I think that this is really a great example of a success that I personally have not been able to equal or see really equaled within our system, although we are likewise exploring the role of the community health worker. And I think you've done a lot of really impressive work to really kind of understand that role and build it in concert with your community health workers. So I think that this idea of sort of flipping the echo on its head and really using it as a way to have sort of the experts in lived experience and the experts in those communities be recognized in that role and encouraged to actually deliver the educational content is a great step forward. And I'm very happy to hear about the level of engagement that you're finding within the provider and health system that you have there, and that they are willing to support and seek funding and extend the series. We have probably just a couple minutes for questions. So Rachel, do you have any questions for Renee?
Yes, I wonder what you found to be the most helpful ways to build trust between health systems and health professionals and the immigrant communities that they serve.
I think there are a few things that have helped us. The Ask the Doc series was a good sort of stepping stone, because there was I represented a consistent presence, and there were a few other doctors that showed what our intent was. I think having people come to the table to include what they thought was important. So asking people, what is it that you need? I may think I know what you need, but what is it that you actually need? So I think honesty and transparency and consistency would be the three principles that have allowed us to build these relationships.
Yeah. I'm struck by the contrast of moving from the Ask the Doc model to the Ask the Community model, which really seems to me to reflect an evolution in the thinking. Are there things that you have done in terms of the way that you've designed or built the infrastructure around the ECHO that have helped you sort of keep that balance in terms of community and professional involvement?
During the Ask the Doc, we sort of developed our guiding principles that we would co-produce these initiatives, that they would be located in the community, and that they would be evidence-based. And those principles, I think sticking to those have really helped us. Some of the people that I work with at the hospital, I don't think have ever co-produced anything with any community members. And so insisting on as near a 50% representation at the table of decision making for these initiatives has been one of the biggest challenges, but also probably one of the more important things that we've done.
Yeah, for those folks watching this who are not really familiar with the U.S. healthcare system, there is really a very deep divide between healthcare and social care, unlike many other countries. And so the idea of sort of stepping outside the walls of the healthcare institution is often very foreign, particularly to larger medical centers, and unfortunately many academic medical centers as well. What are some of the biggest challenges that you have faced or anticipate as this project moves forward?
I think not being co-opted by the big institutions is probably the biggest challenge that we face. And another is to keep a foot on each side and walk that line in between these two worlds and continue to promote that dialogue that's mutually respectful and bidirectional. Mm-hmm. But I have more difficulty keeping the institutionally based that side of the system aligned philosophically with what we're trying to do than I do with the community. It's a lot easier to co-produce with the community than it is with the big institutions. Yeah.
All right, we're almost out of time. I did promise our viewers that we would give them a couple things to mull about during their discussion time if they wish. Rachel, is there something that you would suggest as a prompt?
One thing I wonder is what innovative things are people doing to move healthcare into the community and meet people where they are to overcome mistrust and build relationships?
Great. So other examples that we could potentially learn from. I'm interested in the topic of measurement, and Renee and her group have done a great job of setting up a whole variety of different metrics that are mostly what we usually do when we offer educational sessions, but we would love to hear also about other ways in which people are assessing and measuring co-production and some of the efforts that they're doing. Renee, you've got a prompt for them?
I think implicit bias is often an uninvited guest at this table. And I wonder if other groups could share their successes with dealing with implicit bias as it comes up, or their experiences with the role that implicit bias plays in their co-produced initiatives.
Great. All right. Well, thank you, Renee, so much for sharing your amazing work. Thank you to everybody out there watching this video. We look forward to hearing your thoughts. And we've included our emails here because we would love to stay in touch with any of you or be in communication in some way. So thank you very much. Enjoy the conference.
Thanks for showing that, Martha. Elke has had to leave, so I'm just jumping in to say thanks very much to all our speakers, and thanks to everyone. There's lots going on in the chat that we can pick up on. We're going to have a short break and then go into breakout rooms to have a bit of discussion. And really, it's a bit of time to reflect on what you've heard. Anything that you think would be useful in terms of what we've heard from our speakers, and also to think, it's very much in the chat about what gets in the way of co-production, and really good discussion about how it can be misinterpreted or not actually come to fruition in practice. So a bit of discussion, challenges, and any ideas about how we might overcome those. We're not going to have time for feedback as we come back in, but we'll see what time we've got, if we've just got time for maybe a key point from each group. So if people can take a quick break, and then we'll find ourselves in breakout rooms. So Lynn's put in the chat, we've got 5 breakout rooms for short discussion, and you'll be assigned them in the break. So take a 5-minute break if that's manageable for people, and then we'll be back. Thanks very much again to all our speakers. But thank you to everyone for joining discussions. We do have a few minutes. I'm just going to pick one thing and maybe ask everyone to just say one thing from their group, if you don't mind. Sorry, I'm wagging my finger, I'm reinforcing one thing. And the thing in our group was very much about the system and the need for transparency. And if we're going to ask, we're asking people to co-produce, what does that actually mean, and how do we support everyone to really create a safe and an equal place for co-production to happen? So Lynn, I think we've got at least one more session to think about this in our world reimagined. So I'm going to ask another group
Beth?
Thanks, Lynn.
Lost Beth, is she there?
Sorry, were you talking to me?
Yeah, Beth, it's 1 point from your group discussion.
Oh, okay. I think the main thing was, how do we start this? I mean, we had a very rapid time in which to discuss that, so I'm not sure I've distilled the main points. So I'm inviting John and Eddie to come in and correct me, but I think the main point was about how do we start that off? How do we begin? And who supports it? Eddie, would you say something different, or John?
No, that was fine. It's getting that kind of off the ground discussions and getting all the key people around the table that sort of crystallise ideas and then having the resources to make it happen. That's how you pull all that together in 3 minutes.
Tracy?
Hi, yeah, I'll keep it quick. I'm conscious of the time. Within our group, an interesting point came up about kind of power imbalance from the get-go. And are there any examples of the community initiating that process of co-production from their point of view? Is this process always initiated by larger institutions and bodies? And that was really interesting. So it'll be good to kind of look at that further.
That's a brilliant point, Tracy. Thanks very much. I think that was in some of the chat earlier on. Dorothy Grace Elder, I think, who was with us earlier on, ex-MSP and also involved in chairing one of the cross-party groups in the Parliament, had raised some of these issues. So thank you for that. And then just in last but not least, just Patricia and Riley, just one point from your groups that you can share, one issue that you raised or that stood out for you in your group discussions. Whoever they were very speedy, I understand that. So just one quick issue. So Patricia first and then Riley.
I cannot turn on my video, but okay, we raised the question again that was in the chat about if you need a definition of co-production to know when it's happening. And Emma showed us a chart that they use, maybe not a closer definition of co-production, but maybe do a differentiation of levels of engagement and to locate where is co-production in these different levels. It was one thing that came out of our conversation. We also talked about the risks of cooptation and resource, and in this case, in Brazil, resources are very important. We talked about populations that are very deprived in terms of socioeconomic and well, how co-production happens in a context with deep inequalities. That can be another important issue.
Absolutely, I think that's a really important point, Patricia, is that when people themselves have few resources and perhaps, as we know, in recovery from the pandemic and so on, people are struggling generally, is that this might see something that's very, very remote from their lives. So how do you make it relevant and give the resources to do that? So thank you. And then last, by no means least, Riley, who I know is coming from Canada at an early hour in the morning. Thank you.
Yes.
Final points.
I think something that our group talked about a couple times is that these co-production initiatives tend to be created and co-produced in the digital realm, and a lot of people with chronic health conditions and people who are older in rural areas might not have the access or even like the digital literacy to interact with those. There's someone gave the example of council members need to use MS Teams, and because Zoom is not secure, but some people are much more comfortable using Zoom and it's maybe a little bit more user friendly. So yeah, the tech issue of it all, of everything needs to be technological, but some of the people a lot of the service users are not that into the technological. So it's the kind of push and pull of that.
Brilliant, thank you. It's a really important point, especially in the current climate when we're living most of our world virtually. And so
yeah,
we've seen a lot of
policy making in Scotland happening this way, and you're right, a lot of people are excluded from that. Any final points, Sheena, from you? Thank you so much, Sheena, from you in terms of finishing up. That was brilliant. There's such a lot of stuff there when you think, and it also has real relevance, as I said at the beginning, to what's happening in Scotland around some of the major reforms that we're facing, that many of us, and certainly the message we're getting, and that many of us know from our own experience, is that those who are hardest hit and who are at the hard end of those reforms are not having that involvement that need to have. So we hear a lot of good words about co-production in Scotland, but I think there's a bit of a journey there.
Absolutely. I'm not going to say any more. I think everyone has summed up beautifully. Thanks, everyone. We've got much to do. I've put a bit in the chat. If there's particular themes you'd like to know about, please let us know. And we've got lots to think about, but how we make this genuine co-production and how we take that forward for our National Care Service, I think is key. So thanks to all our team and all our colleagues from all over. It's morning, afternoon, evening with everyone. Thanks very much. And we'll wait on if anyone does want to have a quick chat about anything. Thanks again.